The unspoken rules of an OR run by a typical surgeon include stand as far away from the operating platform as you possibly can, do not move at all, and for the love of God, please don't faint. Whereas a typical student would listen and glue themselves to the back of the surgical room, I lack the tendency to abide by stipulations that restrict my ability to learn as a student. And as a result, I took a leap into neurosurgery. From the precise burr holes made by the neurosurgeon to the delicate incisions made by his blade, from the incredible vision he displayed to his intricate removal of the tumor, every aspect left me wanting more. Thinking back to this surgery, I see now what I wanted. It left me wanting to taste the thrill of saving a life. Hi, my name is Sai Research, and this year in ISM, I have chosen to study neurosurgery in order to gain a deeper understanding over the extensive and demanding procedures that are within its domain. In my research, I've tried to branch out in all different directions, approaching each therapy method with the intent to learn. There are quite a few trial therapies in neurosurgery, and I've also looked into the current research merits of their developments. To start off, I looked into adjuvant radiotherapy for atypical meningiomas. These tumors are a subdivision of the grade 2 tumor classification. These are able to be treated, although they have their nagging recurrences. The radiotherapy was designed as an aggressive initial approach to the tumor to attack it head-on with a great amount of precision. Although initial studies did not show improvement, I learned recently that recent studies have shown that the therapy is working, and it's providing an element to show that continued research yields results over time. Next, I focused on a case study, which was a rare double diagnosis. This 25-year-old patient had spastic measures before falling and being admitted into the hospital. An MRI would show that a lesion, which eventually led to a diagnosis of a brain tumor. And then later, further testing showed focal points of demyelination, which is, as you can see here, a neuron has myelin around its axon, and demyelinization means that it's wearing off. So it's essentially a muscle degeneration. And this double diagnosis was caught late by the doctors who were on the case, and eventually they ended up treating the patient. So finding these double diagnoses can assist in treatment greatly. I then researched a newly emerging procedure known as LIT, or laser interstitial thermal therapy. Like many of the newly emerging techniques, LIT has proven to be a salvage procedure. Once a tumor is determined to be inoperable, the procedure is then performed on the patient. This is due to the fact that LIT therapy has not shown to be effective in reducing tumor sizes with statistical significance. This again shows the technological improvements that are constantly evolving in the medical field can always be further studied. The next procedure I studied was the intraoperative 3T MRI. 3T stands for 3 Tesla. And this is one performed when, this is an MRI used when performing a hemispherectomy, or the removal of one hemisphere of the brain. This is usually used to correct seizure-like symptoms, and those symptoms can get to be fatal due to extreme trauma. In the 32 cases studied in this case study, 30 of them were successful in completing the hemispherectomy, with 36% of the cases using information from the MRI. The MRI essentially functions to show the doctors on, or the surgeons on call, if the corpus callosum, or the structure connecting the two hemispheres of the brain, have been completely severed or not. This, due to a significant benefit from using this procedure, we should see it in the near future being standardized into all neurosurgical procedures. Although my class time in the UNT trip was quite limited due to professor absence and in-class testing, I was still able to gain some knowledge as to the interaction between neurons and the muscles and their actions. I learned about reflex arcs and how muscles respond to certain neural impulses. The research I've done has really expanded my knowledge and made me more adept at turning conversation to gain the most of my informational interviews. For starters, I interviewed Dr. Alan London, a general surgeon at the Surgical Associates of Collin County. There I saw many general procedures such as laparoscopic cholecystectomies, intral hernia repairs, and other lesion repairs and hernia repairs. I shadowed Dr. London over the summer, so my interview was very comfortable as we both knew each other already. From Dr. London, the main thing I learned is that entering this field of medicine, the key thing is to make sure that you're in it for the right reasons. Entering in for money or to become rich is not all that, but you have to be in it to want to help people. You have to be in it to work hard and make sure that your patients have the best care. You have to be able to help, and you have to want to help others while working long hours in order to survive as a surgeon. We also talked a little bit about how government regulations in recent years have changed how surgery works. And with the implementation of new insurance policies and various stipulations for surgeons in operating rooms. He said that operating and communicating with patients is becoming more difficult and patients are becoming harder to deal with. Next, I interviewed Dr. William Bannister, a neurosurgeon mainly affiliated with the Texas Health Presbyterian Hospital in Plano. This was a phone interview, so I had to adapt my style of speaking to properly communicate and get my point across. But from Dr. Bannister, I took away that neurosurgery is a mystery, and entering the field, I have to want to solve the mystery in order to thrive. Knowing that I love the challenge, this is inviting for me in my future. He said that tumors are always a mystery, and it's our job to pinpoint them. He enjoys the concept of locating a tumor and then attacking it and removing it completely. After this, I interviewed Dr. William McCullough, a neurosurgeon at the Frisco Spine Institute. He was the first surgeon that I've talked to in over 2 years of my health science courses and clinical practicals that said that he invites the variability of surgery. Variability simply meaning that I should expect something new each day. Most surgeons tend to stray away from this, as having a standard procedure each day is easier to get adapted to. But Dr. McCullough invites the variability. I also learned that life after residency as an attending in a big hospital is a very key opportunity that he delved in on. And the ability to teach students and work under an institution is a great opportunity for me later in the future. Dr. McCullough specialized in skull-based surgery, and from him I learned about various procedures such as meningioma resections and astrocytoma resections and many tumor resections from the skull base. And we talked about how cerebral vascular surgery is different from spinal surgery and how he's specialized to do both in his surgical associates. Lastly, I interviewed Dr. Thomas Ellis, a neurosurgeon at the Fort Worth Brain and Spine Institute. From him, the simplest thing I took away was that you need passion to get to where you want to be. Dr. Ellis, even while interviewing me, was mesmerized by the words he was saying, and everything he seemed to say just seemed to excite him just as much as it amazed me. A memorable thing from my interview with him is the fact that he cited not being able to do anything to help a patient as the single most difficult thing in the field. Not the surgery or the long hours or the intensive schooling or any of that, but just the hopelessness. This really resonated with me, as I'm frustrated by the inability to do something. Dr. Ellis did a fellowship in cerebrovascular surgery and performs aneurysms, tumor resections, hemispherectomies, and all the procedures dealing with the cranial structures of the brain. And we talked about how this is my interest and how I should pursue this. As I went to more interviews, the more confident I got and the more I asked and learned. With this, I pursued my original work. My original work is, I based it around deep brain stimulation, which is the introducing of an electrode through a slender steel device that was created previously, and they place this into either one of 3 spots in the brain, depending on the type of patient and the type of therapy that needs to be done. It essentially fixes muscle relapses or the inability of functional for a muscle, and by stimulating using the electrode, the muscle continues to function again. And for my original work, I decided to create a catalog of different types of patients with their types of health facts and see like which of the 3 areas the electrode stimulation would work best. In the words of Blaine Lee, no matter where you are in life, no matter what your situation, you can always do something. You always have a choice, and the choice can be power. As I go through the ISM program, accumulating experience and knowledge on the way, I hope to turn into that choice for people and the general public, and into the power to operate on any who need it, and prime myself to walk out of any OR I walk into in the future victorious. Thank you.